Okay, older people's mental health liaison. I think the first thing we need to do is look at what we know. In Doncaster, we've roughly got about 720 beds. Of those beds, 60% are occupied by older people. Of those older people, 60% will have some sort of mental health problem, specifically dementia. So when you break all that down into numbers, you're talking roughly at any one time about 200 beds being occupied by older people with mental health problems. What that also told us is that those people who had mental health problems in acute hospital tend to have poor outcomes and poor experiences. Their length of stay tended to be longer. Their readmissions were higher than the norm. They actually went to care more and went home less. And they had more falls or more complaints generated by that client group. And their relatives really upset about the experience of their loved ones in acute hospital. So what we wanted to do was a commissioning partnership which involved all stakeholders, the council, the DBH, ourselves as commissioners, users, carers, and Ardash as Mental Health Trust. We wanted to actually come up with a way of actually addressing those consequences. So between us, we've commissioned an older people's mental health liaison service as a pilot. And that pilot's been ongoing for the last 12 months.
The benefits of the Older People's Mental Health Liaison Service have been to improve the experience for older people with mental health problems in acute hospitals by placing them at the centre of their care, empowering them and involving them in discharge from hospital. I think education and training of staff has completely raised awareness, and the partnership working between the Older People's Mental Health Liaison team and the acute hospital staff has put mental health in older people on the agenda, whereas potentially that could have been missed, resulting in premature admission to full-time care and discharge pathways not being appropriate, whereas now it's more streamlined and seamless. It's through that joint working and collaboration, it's putting mental health staff together with acute hospital staff so that the complexity of needs of older people with mental health problems is done jointly.
I've worked with Jo and her team for a good 2 or 3 years now, and I think what's really reassuring is the fact that we find that we've got this expert knowledge that is we can tap into it very easy. That gives us confidence to do what we're doing and to move the patient journey forward. So ultimately the patients get a much better deal.
The impact can be quite subtle but detailed. Practical tasks such as make meals and drinks was organised arguably quite poorly in the past because people weren't sensitive to what the person could and couldn't do if they had dementia. So we had concerns in the past whether there be a number of drinks at the end of a lady's bed because she'd not been attending to those. But on the ward, after we've been working with the team, their effectiveness in delivery of care had improved strikingly. But it's bringing in a culture with a specificity and a detail of how things are done that improves qualities of care.
The new system we've got now is a proactive case finding system where the nurses review all patients with any mental health related conditions, in particular dementia, depression and delirium. So automatically people are getting reviewed and assessed at a much earlier stage, and that prevents the potential for escalation. Also what arises from that is that often if someone's known to the mental health service, the early assessment results in the whole clinical team realising that the person who might have altered behaviour, that's not a new thing. So it reduces the need for investigation, it reduces delays and reduces anxiety and worry and improves communication. So right at the start you've got better communication between all the team caring for the patient.
I think the biggest thing they do is to improve the flow of information from the mental health team to the acute medical team. If we have to wait and things dawn on us slowly when family members come and tell us what's happened in the past, it takes a long time. But have a mental health team, for instance, tells what's going on. It saves days in the management of the patient. So the main thing is we know far more about the patient and we're not having to reinvent the wheel. That is, I think, the biggest thing.
After a meeting at the infirmary, Billy Joe guided my mother back to her bed, and I walked beside Billy Joe, and I was impressed how kind and understanding she was towards my mother. She was extremely patient. My mother cannot walk fast, and she kept asking my mother, was she all right? Was she comfortable with the way that she was walking with her. Did she need any support? She took her arm, and I was really, really impressed of the whole situation.
I was not happy and sat there and insisting that I needed to see somebody, that I was concerned about my husband's mental state. I sat there and Lynn turned up and she spoke at length with Les and then looked at me for confirmation that what he was saying was right, because he was not at that time in Doncaster at all. When she'd finished talking, she just leant forward to me and she said, "I'm sorry, love, I don't think you're going to be able to have him home. It's not safe." And I can remember going, because at long last somebody was listening to me and was believing what I was saying.
What has the pilot shown for us? Well, the pilot's almost complete now. We're in the final stages of writing our evaluation report. And the findings are really, really positive. The pilot has showed us that we've actually reduced length of stay for this particular client group by almost 2 days. That would actually equate to £1.5 million worth of money that we would normally have spent on this client group being in an acute hospital. From an outcome point of view, is that despite the increased activity and the reduced length of stay, readmissions have stayed the same, which means the care is still good despite it being shorter. We've had a reduction in falls from people with mental health problems, which is a fantastic piece of news. Data actually shows us if people with mental health problems, if they break a femur, they're more likely to die within 12 months. So actually to reduce falls in the acute hospital is absolutely fantastic. From an experience point of view, we've got evidence from carers saying their stay in an acute hospital was very, very positive. They got the care that they needed, they got the care at the right time and in the right way by people aware and understanding of mental health problems in the acute hospital. So all this is absolutely fantastic news. Now, one quote really stands to mind about the beds that the OPMH Mental Health Liaison Service have been helping with, which is the Gresley unit. And one quote which says it was like going into a new hospital, a different hospital. Now that to me says we're doing something right.